You know, when you pick up a really young baby and they just kind of melt in your arms, almost like holding a little soft toy with no stuffing.
Uh-huh.
That feeling of floppiness is actually our starting point today for a really fascinating dive into the world of pediatric health.
Hypotonia.
Exactly. That floppy description, while, not strict medical jargon, it perfectly captures what we mean by hypotonia. It's a genuine reduction in muscle tone,
Right.
leading to this noticeable decrease in strength and muscles that feel, well, unusually limp. Now, the really key thing to remember right off the bat is that hypotonia itself isn't a diagnosis.
Okay.
Think of it more like a vital sign, a signal that something else might be going on that we need to investigate further.
Okay, so it's not the end of the story. It's the beginning of a potential investigation. Because from what I've seen, hypotonia isn't just one simple thing with one cause.
Precisely. We broadly think about the origins in two main categories. Central, meaning the issue stems from the brain or spinal cord, the body's command center.
Right, the CNS. Or peripheral, which indicates a problem with the network of nerves that carry signals to the muscles. Or maybe with the muscles themselves.
And what's interesting, too, is that it can show up acutely.
Yes. What's also interesting is that even a child who's fighting off a severe acute illness, like, say, a serious infection, such as septicemia, can temporarily show signs of hypotonia.
Huh.
And for newborns who experienced a lack of oxygen around the time of birth, a condition we call hypoxic ischemic encephalopathy, or HIE.
Yeah.
Hypotonia is unfortunately a common finding there.
So for this deep dive, our mission really is to get our heads around hypotonia, especially this concept of benign congenital hypotonia. We're going to sift through this information, pull out the core knowledge to give you a clear, concise understanding, perfect if you're revising, studying, or just trying to get a solid overview.
Absolutely. Let's start by defining hypotonia a little more formally. As we've said, it's that floppy or limp feeling in the muscles. This can affect the entire body. We call that generalized hypotonia, or it might be more localized to specific areas, like just the arms or legs.
Okay.
And as we touched on, the root of the problem can be in the central nervous system or the peripheral nervous system, that sort of vast network of nerves and muscles outside of the brain and spinal cord.
And that point about acutely ill children is important to remember, isn't it? It highlights that hypotonia isn't always a sign of a long-term or congenital condition.
Exactly. In those situations, it's often a temporary response by the body to the stress of the illness. Now, when we see hypotonia in newborns who've experienced encephalopathy brain issues, the most frequent cause is indeed HIE, where the brain didn't get enough oxygen.
Right.
Our notes also mention another term you might encounter, congenital hypotonia with favorable outcome, often shortened to CHFO.
CHFO.
Think of CHFO as a more optimistic label, really.
CHFO, good to have that one in our toolkit. Now, let's really dig into this benign congenital hypotonia specifically. What does that term actually tell us? What's the key insight there?
So, benign congenital hypotonia, or BCH, describes a group of infants who are born with mild hypotonia, but who generally go on to have normal or near normal development.
Okay, so benign meaning a good outlook.
Exactly. The fascinating thing about BCH is that often, despite the initial floppiness, we don't actually identify a specific underlying cause. It's almost as if their motor system takes a slightly slower start but then catches up naturally. So BCH is essentially a label for hypotonia, where things tend to improve on their own after we've excluded other things.
Okay, so how do doctors actually determine if a child fits into this benign category? Are there specific criteria or a constellation of features they look for?
Yes, there are diagnostic criteria that help us identify BCH.
Okay.
Firstly, the hypotonia needs to be present very early, typically right from birth.
Okay, from birth.
Secondly, despite feeling floppy, these babies usually show active movements of their arms and legs, and their tendon reflexes, that knee-jerk reaction, for example, are typically normal.
Right, so active movement, normal reflexes.
We also observe mild delays in reaching motor milestones, like sitting or walking. But crucially, these skills improve as the child gets older.
Improvement over time is key.
Definitely. And importantly, blood tests looking at muscle enzyme levels, like CK, come back normal, as do the results of electromyography, EMG, and nerve conduction studies.
Ah, the EMG.
Think of EMG as a way to check the electrical activity of muscles and the nerves that control them. Normal results here help us rule out specific neurological problems.
Makes sense.
And finally, if a muscle biopsy is performed, which isn't always needed, The tissue looks normal under the microscope.
Got it.
So it's this specific combination, early hypotonia, active movements, normal reflexes and tests, and that trend of developmental improvement that points towards BCH after we've ruled out other specific conditions.
That gives us a much clearer picture of what benign congenital hypotonia looks like. But let's zoom out again. What about the broader reasons why hypotonia happens in the first place? What are the different etiologies, the underlying causes?
The causes of hypotonia are really quite varied. Our notes broadly categorize them as genetic disorders, conditions passed down through families,
Right.
neuromuscular conditions, which directly affect the nerves and muscles, abnormalities of the central nervous system, the brain and spinal cord,
Mm-hmm.
metabolic disorders, which involve problems with the body's chemical processes, and also specific genetic syndromes.
Can you give us some examples of each of those categories, maybe some of the more common associations people might recognize?
Certainly. Common genetic conditions associated with hypotonia include things like Down syndrome and Prader-Willi syndrome,
Okay.
hypothyroidism, where the thyroid gland doesn't produce enough hormone, is an example of a metabolic disorder that can cause it. Cerebral palsy, which results from brain damage affecting muscle control, is another important central nervous system cause.
Those are some of the more widely recognized links. What about some of those other causes our notes mention, more specific neuromuscular ones?
Yeah, we also see hypotonia in various neuromuscular conditions like spinal muscular atrophy, SMA, spina bifida, Guillain-Barré syndrome, myasthenia gravis, and different forms of muscular dystrophy and myotonic dystrophy.
A wide range there.
Definitely. These conditions directly impair the function of nerves or muscles, leading to that reduced tone and strength.
And the breakdown of congenital hypotonia by category is really striking, isn't it? With the vast majority originating in the central nervous system.
It is. Our information suggests that central nervous system issues account for a really significant proportion, somewhere between, say, 66 and 88% of congenital hypotonia cases.
Wow, that high.
Yeah. The remaining cases are due to problems in the peripheral nerves, both the motor nerves controlling movement and the sensory nerves or the neuromuscular junction, which is where nerves communicate with muscles or the muscles themselves.
So that high percentage of CNS involvement is a key insight when thinking about the initial diagnostic approach.
Absolutely. It definitely guides the initial thinking.
So if we consider who might be at a higher risk of developing hypotonia, what are some of the key risk factors that come into play?
Well, the risk factors largely mirror the underlying causes we just discussed. A family history of genetic conditions or neuromuscular disorders certainly increases the risk.
Makes sense.
Prenatal factors, particularly premature birth, are also a significant risk factor. Additionally, the presence of other developmental abnormalities identified before or at birth can also be a risk factor for hypotonia.
Now let's delve a little deeper into the why. At a fundamental level, what's actually going wrong in the body to cause this reduced muscle tone? What's the underlying pathophysiology?
Essentially, hypotonia arises from a disruption in the normal pathways that control muscle tone. This involves a really complex interplay of signals between the brain, the spinal cord, peripheral nerves, and the muscles themselves.
Okay.
Dysfunction at any point along this pathway can lead to hypotonia. However, the precise mechanisms at a cellular or molecular level will differ significantly depending on the specific underlying cause. It's not one single mechanism.
That makes sense. With such a wide array of potential causes, the list of conditions we need to consider the differential diagnoses must be quite extensive.
It certainly is. When a child presents with hypotonia, clinicians need to consider a broad range of possibilities. As our notes highlight, this includes other neuromuscular disorders like various types of muscular dystrophy, other myopathies, which are muscle diseases, and neuropathies, nerve diseases,
Right.
as well as neurological conditions like cerebral palsy and spinal muscular atrophy. We also need to think about other neurological or genetic disorders where hypotonia might be just one of several presenting features.
And the distinction we talked about earlier between central and peripheral origins is crucial for narrowing down that list of possibilities, right? For the differential.
Absolutely. Determining whether the primary issue lies in the central nervous system or perhaps in the peripheral nerves or muscles helps to direct further investigations and refine our list of potential diagnoses. It's a key branch point in the diagnostic pathway.
You mentioned earlier about needing to rule out other conditions before diagnosing benign congenital hypotonia. What are some of the specific conditions that we need to be particularly careful to exclude?
Right, so our notes list several important conditions that can present with hypotonia from birth but have different underlying causes and, crucially, different long-term outlooks compared to BCH.
Okay, like what?
These include things like congenital myotonic dystrophy, Niemeline myopathy, various metabolic disorders such as Zellweger syndrome, Prader-Willi syndrome again, where the Hoffman disease, which is a severe form of SMA,
Right, SMA type 1.
Down syndrome, and even infantile botulism. Performing specific investigations to rule out these conditions is a critical step before arriving at that diagnosis of benign congenital hypotonia.
Shifting our focus slightly to how common hypotonia is, the epidemiology seems a little unclear from the notes. What do we know about how frequently it occurs?
That's correct. Our information indicates that the exact prevalence of hypotonia in the UK isn't really well established. What we do know is that it can affect individuals across all age groups and is frequently observed in children who are experiencing developmental delays.
Okay.
When we focus specifically on congenital hypotonia present from birth, the true incidence is also unknown. This is partly because, well, it can be diagnosed and reported in different ways. However, there does appear to be a familial tendency in some instances, suggesting a possible genetic component in certain cases, and it seems to affect male and female infants roughly equally. No strong gender bias.
Okay, so we have a good understanding of what hypotonia is, the various reasons it can occur, and who might be affected. Now, let's talk about what it actually looks like in a child. What are the typical clinical presentations, the signs and symptoms that might raise a red flag?
Yeah, the signs and symptoms of hypotonia can be quite noticeable. Parents might describe their baby as feeling exceptionally floppy or limp when they pick them up, just like you said at the start.
That initial sloppy feeling.
Exactly. There's often a general lack of good muscle strength, which can lead to delays in reaching important motor milestones, like gaining head control, learning to sit up, crawl, and eventually walk.
Delayed milestones are a big one then.
A very common finding. You might also observe that the baby has decreased reflexes on examination. Poor control of posture is another common sign, as are difficulties with coordination and movement in general.
Right.
Because of the muscle weakness, we often see delays specifically in gross motor development, those larger movements like rolling over or crawling. And interestingly, some individuals might even experience recurring episodes of muscle pain, particularly during or after physical activity.
And are there specific physical signs that a healthcare professional would look for during an examination that might suggest hypotonia, things they'd note down?
Yes, there are several physical signs. Due to weakness in the core muscles, there can be an exaggeration of the natural curves of the spine. For example, hyperlordosis, which is an increased inward curve of the lower back.
Okay, the spinal curve.
The abdomen might appear to protrude more than usual. When the child is standing, they might have flat feet.
Flat feet when standing.
Conversely, when their feet are not bearing weight, you might notice pes cavus, which is a high arch. Walking on their tiptoes can be another telltale sign, as can the inability to walk on their heels when asked. That's quite common.
Heel walking difficulty.
Yes. Joint hyperlaxity, or being very flexible, seemingly double-jointed, is frequently observed too. Information from the parent's history is also really important. For example, if there were any complications or trauma during the birth process. And finally, of course, a careful assessment of the baby's muscle tone and reflexes during the physical examination itself is absolutely crucial in identifying hypotonia.
So if a clinician suspects hypotonia based on these signs and symptoms, what kind of investigations would they typically order to try and pinpoint the underlying cause? What tests are we talking about?
A thorough investigation is essential to try and determine the root cause. Our notes outline several key investigations. Initially, perhaps an infection screen, which might include taking samples of cerebrospinal fluids, CSF, and blood cultures, could be done to rule out infections, especially if it's an acute onset.
Rule out sepsis, for example.
Exactly. Blood tests to check levels of glucose, magnesium, and especially creatine kinase, CK, can provide valuable clues about potential metabolic or muscle disorders.
CK for muscle breakdown.
Right. Karyotyping, which analyzes the chromosomes, can help identify genetic abnormalities like Down syndrome. Imaging studies like CT or MRI scans of the brain and spinal cord might be performed to look for any structural abnormalities in the CNS. A muscle biopsy, where a small sample of muscle tissue is examined under a microscope, can be very informative in suspected muscle disorders, though it's more invasive.
And the EMG.
Electromyography, or EMG, is particularly useful. As our notes highlight, it can help exclude certain neurological diseases. And importantly, in the context of benign congenital hypotonia, the EMG results are typically normal.
So a normal EMG supports BCH.
Yes. It supports the diagnosis by helping to rule other things out. Nerve conduction studies, which assess how well electrical signals travel along the nerves, are often performed alongside EMG.
Okay, quite a workup potentially. Once a diagnosis of hypotonia is made, or at least suspected while investigating, what does the management typically involve? What's the approach to care?
Well, the primary goal of management is always to address the underlying cause, if one can be identified and if it's treatable.
Treat the cause first.
Always. However, regardless of the specific cause, supportive care plays a very, very important role. This includes physical therapy, which focuses on improving muscle strength, coordination, and preventing muscle shortening or contractures.
Physio is key.
Absolutely. Occupational therapy can help with developing skills for daily living things like feeding, dressing. Speech therapy might be necessary if there are difficulties with feeding, swallowing, or communication.
Makes sense.
Assistive devices like braces or walkers might be used to aid mobility and function. And it's also crucial to manage any associated symptoms or complications that may arise alongside the hypotonia.
And specifically for congenital hypotonia, particularly the benign form, are there any particular treatments or medications that are typically used?
Our notes specifically point out that there isn't a specific drug therapy for congenital hypotonia in general, including BCH. However, physiotherapy is often incredibly beneficial.
So physio again.
Yes, it's central. It helps improve muscle strength, range of motion, and prevent the development of those muscle contractures we mentioned. It really is a cornerstone of supportive care for these children.
What about the long-term outlook for children with hypotonia? What's the typical prognosis? Does it depend heavily on the cause?
It really depends heavily on what's causing the hypotonia in the first place. That's the main determinant. As our notes mention, some underlying conditions can be managed effectively, leading to significant improvements with appropriate interventions. However, for genetic or progressive neuromuscular disorders, like certain muscular dystrophies or SMA, the long-term outlook might be more challenging.
Right.
Now, when we talk specifically about benign congenital hypotonia, the prognosis is generally very good. It's typically a self-limiting condition.
Meaning it gets better on its own?
Yes. It tends to improve naturally over time, and it's usually not associated with intellectual disabilities. In most cases of BCH, the hypotonia resolves, or mostly resolves, by the time the child reaches puberty.
That's quite reassuring for BCH. And what kind of complications might potentially arise from hypertonia if it's not managed effectively, or perhaps if the underlying cause is more severe?
Yeah, potential complications can include delays in reaching those important developmental milestones we talked about, ongoing challenges with mobility and overall physical functioning. Respiratory issues, potentially due to weakness of the muscles involved in breathing, and difficulties with feeding and swallowing, which can impact nutrition.
Feeding difficulties are common.
They can be. Additionally, there can be other medical conditions that are associated with the specific underlying cause of the hypotonia. But, as our notes emphasize, early and appropriate management, particularly physiotherapy and other supportive therapies, can play a significant role in minimizing the risk and severity of these potential complications.
So to really bring it all together then, our deep dive into hypotonia has shown us that it's this sign, this finding of reduced muscle tone with a surprisingly wide array of potential causes. It can range from temporary illnesses right through to more persistent, sometimes genetic conditions.
That's right.
And while the term floppy baby can sound concerning, it's so important to remember that there's this category called benign congenital hypotonia, or BCH, where children typically have mild symptoms and a positive long-term outcome, often seeing a resolution of the hypotonia by puberty.
Exactly. Recognizing those specific diagnostic criteria for BCH and diligently ruling out other conditions is absolutely key for accurate diagnosis and appropriate management.
And understanding those broad categories of origin, whether the issue starts in the central nervous system, the peripheral nervous system, or is linked to an acute illness, that's fundamental to guiding the diagnostic process effectively, isn't it?
It really is. It helps structure the whole approach.
This has been such a helpful breakdown of a really complex area. It's amazing how that initial observation of a floppy baby can open up such a detailed exploration of underlying medical possibilities.
It is, and it really highlights the importance of careful clinical assessment, thoughtful investigation, and a holistic, multidisciplinary approach to understanding and managing these conditions.
That brings us to our final thought for you, the listener. Given the sheer diversity of potential causes of hypotonia we've discussed, what do you think are some of the biggest hurdles that clinicians face in achieving an early and accurate diagnosis? It's definitely something worth pondering.
A great question to reflect on.
And for those of you looking for more fantastic resources to support your learning and revision, especially for pediatrics and conditions like this, be sure to check out passthemsra.com and freemsra.com.
Really valuable resources there.
They are indeed invaluable tools for further exploration of this and many other important topics.